back to my channel. When infection turns into pus inside your chest, that's empyema. Let's understand it in just few minutes. But before understanding empyema, you have to clear out the confusion between two terms, emphysema and empyema. Emphysema is the condition of the lung marked by abnormal enlargement of the alveoli with loss of pulmonary elasticity, whereas empyema is the collection of pus in the pleural space, which may be as thin as serous fluid or so thick that it is impossible to aspirate even through a wide bore needle. Microscopically, in pus, neutrophil and leukocytes are present in large number. An empyema may be classified into two types, loculated or encysted. An empyema may involve the whole pleural space is known as loculated or only part of it is known as encysted and is usually unilateral. It is always secondary to infection in neighboring structure, usually the lung, most commonly due to bacterial pneumonitis or tuberculosis. Other causes are infection of hemothorax following trauma or surgery, esophageal rupture and rupture of subphrenic abscess through the diaphragm. Both pleural spaces are covered with a thick, shaggy, inflammatory exudate. The pus in the pleural space is often under considerable pressure, and if the condition is not adequately treated, pus may rupture into bronchus, causing bronchopleural fistula or pneumothorax, or track through the chest wall with the formation of subcutaneous abscess or sinus. Clinical assessment. An empyema should be suspected in patient with pulmonary infection if there is severe pleuritic chest pain or persisting or recurrent pyrexia. Clinical features of empyema. Systemic features include pyrexia, usually high and remittent, rigors, sweating, malaise and weight loss, polymorphonuclear leukocytes, high CRP level, and the local features include pleural pain, breathlessness, cough and sputum, usually because of underlying lung disease, copious purulent sputum if empyema ruptures into bronchus, and the clinical signs of pleural effusion. The investigation is most commonly the chest X-ray. Empyema in chest X-ray form a D-shaped shadow against the inside of chest wall. Ultrasound shows the position of fluid, the extent of pleural thickening, and whether fluid is in single collection or multiloculated, containing fibrin and debris. CT provides information on the pleura, underlying lung parenchyma, and patency of the major bronchi. Ultrasound or CT is used to identify the optimal site for aspiration, which is best performed using a wide bore needle. If the fluid is thick and turbid pus, empyema is confirmed. Other features suggesting empyema are fluid glucose level of less than 60, LDH level of more than 1000 IU per liter, or fluid pH of less than 7. However, pH measurement should be avoided if pus is thick, as it damages blood gas machine. The pus is frequently sterile on culture if antibiotics have been already given. The management of empyema. The empyema will heal only if the infection is eradicated and the empyema space is removed, allowing opposition of visceral and parietal pleural layers. This can only occur if re-expansion of the compressed lung is secured at an early stage by removal of all pus from the pleural space. When the pus is sufficiently thin, this must be easily achieved with insertion of wide-bore intercostal tube into most dependent part of empyema. If the initial aspirate reveals turbid fluid or frank pus, or if loculations are seen on ultrasound, the tube should be put on suction and flushed regularly with 20 ml normal saline. If the organism causing the empyema can be identified, the appropriate antibiotic should be given for 2 to 4 weeks. Empirical antibiotic treatment, example intravenous amoxiclav or cefuroxime with metronidazole, should be used if the organism is unknown. That's all about empyema, from its causes to management. Understanding it early can make all the difference in saving a patient life. If you found this video helpful, don't forget to like, share and subscribe for more such quick medical explainers. Thank you.